Good evening, everyone. So my name is Dr. Eva. Today, we're just going to have a short session on head injuries. Of course, this webinar comes under Bite Medicine. So they have question banks available, which follows the single best answer method, which questions for each categories in each topic, such as investigations, diagnosis, and management. And also they have online textbooks which cover a lot of main topics that would be good for medical students especially. So today's topic is head injuries. Our main aims and objectives for the course is that we cover the following topics. So we're going to look into the anatomy of the skull and meninges, know what are the relevant questions that we should be asking in history taking, find out the criteria for radiological imaging, find out the different types of bleed and identify them, and based on radiological imaging, and of course, what are the treatment options that are available, both medical and surgical. So diving into the anatomy, we're going to start with the anatomy of the scalp. The word in itself stands for skin, subcutaneous tissue, aponeurosis, loose connective tissue, and periosteum. We're not going to go into the details of the scalp because most scalp injuries, if it's like a laceration, we suture it up. If it's like a blunt force hematoma or something, usually it's just followed on conservative management because they resolve on their own. The blood supply, of course, is by the superficial temporal artery, the posterior auricular, and the occipital, all are branches of your external carotid artery. Then moving on to the skull in itself, we've got 5 bones which fuse together to form the skull. We've got the frontal, the parietal, the temporal, occipital, and the sphenoid, which you cannot see from the outside because it's like inner and medial force going in like that. And we've got the 4 main suture lines. We've got the coronary suture line, the lambdoid suture line, the sagittal, which goes in the middle. So you've got the coronary in the front, the sagittal, the lambdoid, and the temporal one. The main things that I would ask you to remember today would be the coronary one, which is in the front. If you actually palpate, you can feel the coronary. You can see like a small bridge that you would feel under your scalp just there, which is the point for your coronary, and your sagittal, which is right in the middle. So a few things that I would ask you to remember in this is your coccus point and your therion. Therion is a simpler point that you'll have to remember, which is basically the joining area of all 4 bones over here. So we've got the sphenoid, we've got the frontal, we've got your parietal, and your temporal. So this point where it joins is kind of important because it's comparatively more thin than the other part of the skull. So it is also more prone for fractures and causing bleeds. So this therion is something that you'll have to keep in your mind. And of course, coccus point is important if you're perhaps doing a neurosurgical procedure like an ICP bolt, or suppose you're doing a burr hole. Coccus point is basically your interpupillary line. So when the patient is on the table, basically you check for their pupil and you go exactly up. And then you feel for your coronary suture right there, and imagine 1 centimeter from the coronary suture anteriorly and 3 centimeters from your midline. So you go up like that, 3 centimeters there and 1 centimeter in front of your coronary. That is where your coccus point is, and that is where you will ideally put your ICP bolt or your burr hole. I hope you understood that. If not, you can always ask me a question in the end. And moving on, we're coming into the skull now. We're coming into the meninges. We've got the dura, the arachnoid, and the pia mater. The dura, of course, has all the dural venous sinuses and the cerebral veins. The arachnoid has the trabecular mesh and these cisterns. Some of the most common cisterns are the ones that we particularly look into, or the interpeduncular cisterns, the chiasmatic cisterns, which is right up below the optichiasma, or the pontine cistern, which is in front of the pontines. A cistern is basically like a gap between your arachnoid and your pia, which is much bigger than the rest of the brain. So you've got a lot more CSF in those areas. And yeah, so like I said, under your arachnoid between the trabecular mesh is where your CSF would be flowing in. And yeah, types of intracranial hemorrhage, if you look into it, of course, there are other types of bleeding that are mentioned here, which ideally, like I said, we wouldn't have to actively intervene in anything because they are all still subcutaneous and they resolve on their own within the next few days or hours. But you will look into these kind of bleedings, and this is more sinister, and that's why they need to be treated as well. So you've got your epidural bleeding, which is just in between your scalp, I mean, not your scalp, sorry, your skull and your dura. And then you've got your subdural, which is between your dura and your arachnoid. And then you've got your subarachnoid, which is below your arachnoid, but then just above your pia mater. As you can see, the subarachnoid is in the trabecular space right over there. Yeah. And types of intracranial bleeding. So when we move on, this image shows more of the intracranial bleed that we can normally see in a lot of patients, especially after trauma. So we've got your extradural, which is outside of your dura. Then you've got your subdural, which is inside of your dura, but still outside of your arachnoid. And then you've got your subarachnoid bleeding over here. Then you've got your intercerebral bleeding, which is inside the parenchyma of the brain. And also you've got your interventricular hemorrhage, which occupies the ventricles of the brain. I hope everyone knows the ventricles of the brain. We've got the lateral ventricles coming into the third ventricle, coming into the fourth ventricle, then going out through the magenta and musca. And yes, pathophysiology, Monroe-Kelly doctrine is something that I think everyone should be aware of. So the Monroe-Kelly doctrine basically says that your brain and the skull is like a box. So inside the box, you've got your CSF, blood, and brain parenchyma. The concept is that the box is a closed box with like one input to like feed the box. And you've got all three of them coming through that. So if one increases in volume, the other two try their best to compensate in one way. So if your blood is suppose increasing, then your CSF will go down. If your brain parenchyma increases because of a tumor or an abscess, then your blood or your CSF comes down. So they compensate in such a way that it is all still intact within the skull cavity. And the normal intracranial pressure obviously is 7 to 15. We try our best to make sure that it's 7 to 15 throughout. And we try to make sure that the cerebral perfusion pressure during this period is also maintained. And that is, of course, your mean arterial pressure minus the intracranial pressure that you would normally see. And if it goes above 20 mmHg, then that's when your raised intracranial pressure comes in and you get all the signs and symptoms of raised intracranial pressure. Some of the symptoms can include vomiting, headaches, photophobia, and all of these. And your signs would always include papilledema. That's something that we notice. And Cushing's triad is something that comes at the end of all of this intracranial pressure rise. So the triad is basically when the pressure rises so much that your medulla starts getting compressed. So you've got hypertension, bradycardia, and irregular respirations. So hypertension is one that leads to the bradycardia because when the pressure increases so much, your baroreceptors get activated and the heart rate goes down. So it's kind of interlinked in that way. So coming to the clinical scenario that we normally see, we've got a 25-year-old woman presents to, sorry, not a 25, 75-year-old woman presents to the ED with a history of sudden onset drowsiness, inability to speak, and weakness of the right upper limb. She was found by her daughter in the morning and was brought to the hospital for further management over a time period of 4 hours. So given that it was a sudden onset and there is drowsiness, inability to speak, yes, there are differentials that you can think of. You can even think of electrolyte imbalance or glucose related or even heart related. There are so many things that you could think of, but we would always, given the weakness of the right upper limb, we would always think of the brain as well. So you or someone who's in neurology or neurosurgery team and you are called to see the patient. In which case, if the patient is brought to ED, and this is after high injury trauma, you would follow the ATLS protocol. If not, if the patient is brought down to the ward, then you start with some normal history taking, which is based on presenting complaints. You check on the onset, the duration, how the symptoms progressed, how long, what were the steps, which came first or which came second, how long did they last, which led to what. You kind of go into all the details of it. And obviously you rule out the criteria for an immediate CT head. So you ask mainly about vomiting, any significant ENT bleeding, or you look into loss of consciousness or even amnesia related to the injury. Then moving on to past history, yes, you do ask about previous strokes, if there was previous residual weakness already persisting in the body, what were the other medical conditions that the patient had, or what would be your, so what could be leading to all of this, leading to all these weaknesses and other complications that you're developing. Personal history, smoking and alcohol is always important. Some patients who are like chronic alcohols are always more prone for bleeding, which a lot of studies have shown. And smoking also affects the blood vessels on a long-term basis. Social history-wise, yes, always ask how the baseline of the patient was, baseline mobilization, how independent she was before, who was she living with, was she able to take care of herself on a daily basis, did she need assistance already, those kind of things. And drug history, yes, if they've had previous strokes or previous heart conditions, then definitely look into blood thinners, because the chances of them taking blood thinners is really, really high. And especially old people on blood thinners, the chances of getting a chronic subdural without any trauma is very, very high. So you will always have to ask for blood thinners if they're taking in their history. Clinical examination, I know everyone hates neurological examination, at least I did when I was in medical school, because it's just relatively very, very long. But then when you start doing it for like 15 patients a day and you have to do the same thing all over and over again, you kind of get used to it. So yeah, you always check into GCS first. I hope everyone knows the subcategories of GCS: motor, verbal, and eye response. You calculate your GCS, and it's always better to take 2 GCS first during the presentation when the patient comes in and you have a GCS value, and then another one 2 hours later, and that shows you the progression. So it's always better to also reassess the patient 2 hours later. So yeah, you start with your baseline GCS, then you move on to neurological examination. If the patient has no weakness and has the ability to walk, always check the gait. And that shows you if there's any spinal cord injuries as well, if there's any pain or anything of that sort. Start with all the cranial nerves. We've got 1 to 12 cranial nerves. I can do a separate session on neurological examination later if you guys prefer, because I know it's like a huge topic in itself. So yeah, so you start with cranial nerves 1 to 12, and then you move on to your limbs, your upper limb and your lower limb. This is something that I find easy to remember. So you just check for power, tone, reflexes, coordination, and sensation. Especially being in neurology, for sensation, you definitely have to check pinprick and soft touch. So you can always just borrow a neuropin or a cotton from the ward and go ahead with your examination. Coordination, for the upper limb, we always check for dysdiadokinesia. And for the lower limbs, we move on with the heel on the shin, and then we drag it along the foot, and we ask the patient to repeat that. That is an easier way to check for coordination. And yes, reflexes, tone, and power. I think pretty much everyone knows that. So like I said, but then if you have any doubts, I could answer them in the end, or I can do a separate session on neurological examination. So we're a bit more clear on that. And yes, always check for AMTS, because in case you do decide to take the patient up for surgery, you will need to assess if the patient has capacity to consent for the surgery. And it also lets you know if the patient has capacity in general to refuse treatment later as well, in case she doesn't want the surgery or something. And you can always use that for your mental capacity assessment later. And investigations, we've got your routine bloods, we've got full blood count, U&Es, and all of the CRPs, LFTs, whatever that you normally ask in your hospital as per your protocol. And any patient for surgery, you will always ask for coagulation, group and save. 2 units of group and save, by the way. So yes, prepare them for surgery accordingly, ECG and chest X-ray. Radiological imaging is what neurosurgery will request immediately, if anything. So CT and MRI, most hospitals find CT to be easily done. So CT is something that we do on spot, such as CT trauma, which involves head, abdo, chest, and then we move on ahead. So nice guidelines for CT. So if you've got a patient who's coming to ED, if he or she fills any of these criteria, then you go ahead with a CT head within 1 hour from presentation. So a GCS score of 12 at presentation, or a GCS score of less than 15 at 2 hours after the injury. So you're giving them a little bit of time to recover from their initial shock, which is assuming that their initial GCS is about 12. So initial GCS about 12, but then after 2 hours, it's still not 15, they're still 15 to 12, then yes, get a CT head, in which case. Suspected open or depressed skull fracture, I think, which will be pretty obvious by like basal skull fracture. You can see the whole raccoon eyes appearance, the hemotympanum, bleeding in and around the mastoid areas, in and around the jaw, like anywhere when you see blood collection somewhere around the base of the skull, then you know that the patient has got a skull fracture. Post-traumatic seizure, there would be like a witness seizure, in which case, and focal neurological deficits, which means there would be like an upper limb weakness, loss of sensation, lower limb weakness, inability to walk. Any of these could be presenting. And the recent guidelines, I think till 2022, we had, initially it was 3 episodes of vomiting, brought down to 2 episodes of vomiting. Sorry. Now 2023 guidelines show that even 1 episode of vomiting is more than enough to warrant an immediate CT head for the patient. Next one. This one is nice guidelines for CT head within 8 hours from the time of head injury. So if you do not get a CT head done within the first 1 hour, these are the criteria that you will check for within the next 8 hours from the head injury. So any patient about 85, 65, and if they've got any visible GCS drop or anything, or if even without the GCS drop, they are about 65, get the CT head done. It doesn't have to be within the first 1 hour, but should be within 8 hours. Any current bleeding, sorry about that. Any current bleeding or bleeding disorders known to the patient or clotting disorders known to the patient, then definitely dangerous mechanism of injury, which means full-blown RTA, like car versus car, bike versus car. Those are, high-end traumas. So you definitely get a CT head for that. And if the patient has more than 30 minutes of retrograde amnesia of events immediately before the head injury. So if they have no recall of what happened, how did they come about it, how did the accident happen, or how did they end up falling on the floor, then definitely get a CT head within the first 8 hours. So let's start with some CT images now. Looking at the image, what bleeding do you think this could be? I'll probably give like a minute or so to answer, but then moving on. It would be an extradural hemorrhage or hematoma. So factors that help us identify it as an extradural hemorrhage is history-wise, the patient could present with a lucid interval, which means they might have loss of consciousness or something during the event, immediately during the injury. They'll recover within 5 minutes, be completely normal, say that they're talking well, they're going about with their regular activities. Then 2 hours later, 3 hours later, they have loss of consciousness again, completely gone. They're like, or their GCS drops, or they've developed weakness, or any of these. That is called as a lucid interval, in which they're completely normal for a period of time. So that is very common in extradural hematomas. Radiologically, if you look at it, there's a lot of chance of finding a bone injury associated with it, because it's still away from the dura, like outside the dura. So the chances of having a skull fracture are quite high. You could have a biconvex border, which I think is the one that helps me all the time. A biconvex border for the hematoma, usually well defined, and does not cross the suture line in the head. So if you look at it, your coronal suture would be somewhere there. It does not cross that. And your lambdoid suture would be here, and it does not cross that. So it does not cross the suture. And the most common artery that bleeds, like I said, it's right over the pterion, would be the middle meningeal artery. The next one that we're looking into is a subdural hematoma. So a subdural hematoma can be an acute one or a chronic one, or an acute on chronic one. And it's very common in old people if it's chronic, and if it's an acute one, it's usually traumatic and it's found in young people. And when it's in old people, especially if the chronic type, there's a gradual progression of the GCS change. So they'll be quite normal. No one would have, they won't have any trauma, they won't have any falls, they won't have any symptoms or any history of anything dramatic happening in their life. But then suddenly, like one day they'll be drowsy, next day they might develop a weakness. So it's more of a gradual progression in the GCS or neurological deficit that kicks in. And when you look at the radiology, you can see that it's mixed density over here. Some of them are hyper intense, some of them not so intense. So that shows that it's an acute on chronic one. So because the acute ones would be, acute bleed would be much brighter than the chronic ones. So you've got this image over here is a mixed one. It's an acute on chronic bleed. Shape-wise, you've got the lunar shape. And yes, a subdural, because it's inside the dura, it's not going to compensate outside anywhere. It's not going to go out, it's not going to have a fracture of the skull and bleed out. So it has to compensate within the box, like I said. So it's going to start pushing the brain matter to one side. And that's where you'll have your master biaxial midline shift more prominent in this than in EDH. And the bleeding is mainly from your diploic veins or the venous sinuses that's there in the subdural space. So subarachnoid bleed, a lot of them are spontaneous, a lot of them are traumatic. If they're traumatic and they're not too significant, we wouldn't actually treat them. We wait for it to resolve on its own. But if there is a significant amount of bleed, and if it's a spontaneous one, then we would definitely treat it. And we need to look into as to why it had a spontaneous bleed. Could be like an aneurysm that is bleeding. So then we'll have to do further investigations like a CTA or a DSA to find out what the aneurysm is or where the aneurysm is and how far enlarged the aneurysm is. And do we need to clip it, coil it, and all of that. So I'm not going into all of those details right now. But then if you see an SAH and you think that it's spontaneous, then definitely treat it. And it's mainly seen in the cerebral spaces. So you've got your sylvian fissures and all the other major fissures over there. So it mainly fills up those spaces and the cisterns that I've showed you in front. So this would be like your pontine cistern because it's in front of your pons right there. And then we're going into intracerebral bleeding. When it comes to intracerebral bleeding, obviously there is intraparenchymal bleed and intraventricular bleed. The intraparenchymal bleed is kind of more common in adults. It can happen secondary to a tumor because in a tumor, obviously you have more angiogenesis, more fragile blood vessels. So it can bleed automatically, or it could be like an aneurysm somewhere in between the brain that's also bleeding. But an intraventricular bleed spontaneously in an adult is quite rare. Children, yes, very common. Through the choroid plexus, it can bleed quite often, but I haven't seen a primary intraventricular bleeding in an adult. So intraventricular bleeding, like how you see in the picture over here, because the bleeding is inside the ventricles, is usually secondary to an intraparenchymal bleed, like how it is over here, a bleed in the thalamus, which has gone into the ventricle because the thalamus forms the lateral wall of your ventricles. So a bleeding from the thalamus pours into the ventricle, and that's how you get the intraventricular hemorrhage, at least in an adult. In a child at least, they might bleed from the choroid plexus, but in adult, A primary intraventricular bleed that starts from the ventricles is quite rare. And the chances that the intracerebral hemorrhage like these raising the ICP is quite high because it goes into the ventricles, it blocks the flow of the ventricles, and then the patient easily develops a hydrocephalus, which is dilatation of your ventricle because of raised intracranial pressure. Radiologically, it's very easy to pick up. You can see a significant hyperdensity lesion in whichever area the bleeding takes place. So how would you treat or how do you monitor these patients that have an rise in intracranial pressure? So one thing that a lot of people do is lumbar puncture. It's quite easy to do. It's a bedside procedure. You can easily measure the opening pressure and you can see what the pressure is. And you can also take the CSF out, which is also therapeutic as well as diagnostic. So you got your pressure, you know that the pressure is raised or not, and you've also taken the CSF out. So that will at least, improve the GCS of the patient temporarily, at least until the CSF or the intracranial pressure builds up again. So I've seen a lot of patients in whom you do a lumbar puncture and their GCS goes up immediately. But maybe 24 hours later, it might drop again because of the CSF building again. But then especially when there's a bleeding that's causing the hydrocephalus, then it becomes a bit more difficult because still it won't drain even if you put a lumbar puncture in the lumbar area. So you can also do an epidural bolt and a subarachnoid bolt. A subarachnoid bolt is something that's very commonly done. You basically drill in the coccus point, which I told you in the beginning, and you put a monitor, like a small kind of a thread like that. You put it all the way in and you connect it to the monitor, and it will give you a proper wave. I can go into the details of the wave. It's mainly as P1, P2, P3, but then it gives a proper wave as to show you that there is proper circulation and that the circulation in the brain is not compromised because of it, because of the raised intracranial pressure. Epidural bolt is not so commonly used because it's not really as accurate as a subarachnoid bolt. You can also do an intraparallel bolt as well and an EVD. An EVD definitely needs an operation theater, needs expert seniors to do it. And you cannot just do it in the ward. So you need to get the operation list ready, the theater ready, the theater team ready, and everyone to do the EVD. So that's something that we don't do it immediately. We first initially try all of these things and then we go into an EVD unless it warrants an EVD to be done immediately because of significantly high pressure. An EVD can be divided into pressure monitor and volume monitor. So when you connect the EVD to the monitor with readings on it, it can be pressure monitored or volume monitored. A volume monitored one is when you make sure that a particular amount of volume is drained every hour. So if you decide 15 ml of CSF should come out every hour, then 15 ml will be drained by that device every hour, regardless of how much CSF is inside the brain. The pressure monitored one is when you keep the EVD at a particular level, usually at the level of your tragus, where the patient is lying down on the bed, and you keep it at a particular pressure. So when the ICP and the intracranial pressure goes above a particular pressure point, then it opens up, it drains it. But till then, it somehow maintains that level. So if you keep it at 15 mmHg, then it will stay closed till the pressure comes to 15. When it reaches 15, it will open up and give out some CSF so that it goes below 15. So basically, that's how it's monitored. And also, it makes sure that a particular amount of CSF is always available within the ventricles or within the body. Management. Obviously, like I said, you'll have to take 2 GCS to compare, one during admission and one 2 hours later or a few hours later. If you see that the GCS is less than 8 at any point, intubate the patient and move into NITU for admission. And then we'll move on to the medical management. So head elevation to 30 degrees. If there is associated cervical injury, always apply a cervical collar. You can use hypertonic solutions such as mannitol or hypertonic saline. this will bring down the edema quite significantly. And hyperventilation is something that we've been very historically following, though there are some studies that go against it. Hyperventilation is basically increasing the respiratory rate of the patient when he's connected to a ventilator, so that all the CO2 gets flushed out. CO2 in general is a natural vasodilator. So when the CO2 comes out, it all constricts, and that kind of like helps bring down the ICP pressure. But again, when there's significant vasoconstriction, you also risk the brain into ischemia or infarct. So that is something that you'll have to balance when you're hyperventilating the patient. Hypertensing the patient, yes, is something that we do regularly for all the patients, especially in NITU. We always maintain the pressure at like the systolic at least at 190 or 200, 210, so that the pressure is so high that the blood forces the blood vessels and the capillaries in the brain to open up and make sure that the brain gets adequate amount of blood supply, even when in the closed cavity, the skull, even when in the skull, the pressure is so high that the blood doesn't get pumped into the cavity. So basically you're increasing the blood pressure so much that it's pushing open all the capillaries so that it gets enough blood supply. That's basically the concept. And so that's how you maintain that cerebral perfusion pressure, CPP, quite high. So that's where you have to make sure that the mean arterial pressure is above 90 and the cerebral perfusion pressure is above 65. Anticonvulsants, calcium channel blockers. Anticonvulsants is something that we give as a precautionary prophylactic measure to make sure that the patients do not develop any epilepsy or any seizures during their episode of increased intracranial pressure. And calcium channel blockers, especially for patients who have had a subbarac, so we give nimodipine for 21 days because that's the window period where the patient can easily develop a vasospasm and then again go into an infarct, again drop in GCS. All of that is bound to happen because of the bleed inside. So you have to make sure that the vessels don't go into vasospasm and don't decrease the blood supply to the brain. That's why we give the nimodipine. And yes, steroids, dexamethasone, just to have an anti-edema measure. Surgical managements, I'm not going to go into the details of it. These are all the options of surgery. We've got burr holes, craniotomies, craniectomies, and cranioplasties. Burr holes is something that we commonly do. We usually put 2 burr holes, one at coccus point and one at wherever the bleeding is quite significant. And we always do it on the side where there is a bleed. And so the concept of putting 2 burr holes is that you can easily wash it, like you give saline on one and wash out in the other. So it makes it easier to wash it out, especially for large bleeds that have clots as well. So this is how you make the burr hole. You drill through, use retractors, wash it, and put a drain in, and suture it up. Craniotomies is when you cut, take a bone flap, and then you have immediate access to it. Craniectomies is when you don't put the bone flap back and it's just covered with skin and meninges. Cranioplasty is when you put an artificial bone flap covered up later. It's usually done as a separate surgery in itself to cover the brain back. And complications that can develop if you keep a patient with increased cerebral pressure for a long time. You can easily develop cerebral herniation or brainstem herniation. A picture here shows your supratentorial herniations and your infratentorial herniations. Like as you can see here, the cerebellar tonsils are coming down, compressing on the medulla. This is of a high risk because it then compromises on your respiratory centers. And that is something that you definitely should be avoiding. So this is like your end stage if your intracranial pressure is not monitored and not maintained less. And yeah, these kind of herniations can also occur, especially when there's a bleed within the closed cavity. Found in neurological deficits, the nerves do die at some point when they don't get enough blood supply. The brain, parts of the brain can also go into an infarct, hence found in neurological deficits, and complications from giving too much mannitol. So you've got hypertension, a rebound increase in intracranial pressure once you stop the mannitol, volume overload, hyponatremia. obviously anything with the neurology, coma and death. And that's about it. Thank you. So if anyone has any questions, feel free to ask right now. If not, and I'll try my best to answer them at the moment. If not, I can always look up and get back to you. Okay, if anyone has no questions, then I think that's about it. If you want me to go through anything else, again, feel free to let me know. If not, thank you so much. I'll just wait for like a minute or so to see how you guys. Oh, cool. So I guess that's it then. Thank you guys. Yeah, bye.